So, how to approach an acute dyspnea case on your Step 2 CK? Today, our discussion would concentrate on the diagnostic algorithm and the diagnostic criteria needed to identify and approach an acute dyspnea case. So, pulmonology is very tricky as far as Step 2 CK is concerned, and one branch of it is the presenting complaint of dyspnea. So, we will be discussing that. Today, our focus will be on acute dyspnea mostly, right? So let's go over. So a case is presented to you, and what it basically says is which of the following is the most immediate and critical next step in management. Now, the best next step in management questions are heavily tested on the Step 2 CK, and they are also sometimes difficult and ambiguous and vague. We need a criteria to approach these kind of questions in order to understand and get to the right answer. So the case says that a 72-year-old man is brought to the emergency department by his family due to acute onset shortness of breath and confusion over the past 3 hours. His medical history is significant for coronary artery disease, type 2 diabetes, and chronic kidney disease. The baseline creatinine is 1.8. He was recently diagnosed with a lower extremity DVT but has not started anticoagulation due to a scheduling delay for his primary care follow-up. On physical examination, he is diaphoretic and agitated. Vital signs are temperature of 101 Fahrenheit, which means he is having fever, heart rate of 132, and respiratory rate of 28, and blood pressure of 88 by 50, which is low because this would be considered an unstable patient. Oxygen saturation of 82 on room air and auscultation of the heart reveals distant heart sounds. Lung fields are clear bilaterally. A stat 12 lead EKG shows sinus tachycardia with low voltage and electric alternance. A portable chest X-ray is unremarkable. So this is the case that is presented. Now, obviously, this is in an emergency department, so this is obviously an unstable patient. And the question is asking which of the following is the most immediate and critical next step in management? And these are your options. We're not trying to make this question difficult, but if you don't know the answer to this, well, towards the end of this lecture, you would definitely understand how to approach these kind of questions. This is an easier example, but the paper would have quite difficult questions. So let's see the diagnostic flowchart. Right, so dyspnea is basically approached as firstly we have to understand that whenever dyspnea is presenting, is the patient unstable or is he stable? Do we have to manage him according to the stability of his symptoms? If his vital signs are stable, then there is a different path that we go towards. And if the vital signs are unstable, then there is obviously a different path that we go towards. So first we check if the patient is unstable or has airway compromise or is stable and has intact airway. Then depending on the sign, if he has unstable vitals or airway compromise, then we go towards the acute dyspnea pathway, which we would be discussing today. And if he doesn't, then we look at the timeline and we further divide it according to the division of acute dyspnea, acute on chronic dyspnea, or chronic dyspnea, which would be discussing, which we would be discussing later on. So, a brief introduction. It says that the algorithm attempts to walk you through a practical way to think about dyspnea. As with most chief complaints, the first question is how sick is this patient? We need to understand if the patient is, as I said, not stable, then we have to first secure the ABCs and then we have to go towards our differential. So broadly, we think of dyspnea occurring over a relatively short period of time or slowly worsening over an extended period of time. It can be helpful to think in order from acute to chronic. So whenever a patient is presenting, we must go towards an acute presentation or acute differential, and then we should go towards the chronic differentials, because an acute presentation is most likely to be immediately dangerous to the patient. For example, pulmonary embolism is an acute presentation and is very dangerous if you do not treat it timely, whereas a malignancy is as a chronic presentation. Right, so this is a basically general overview, and there is a mnemonic given which helps you to remember certain conditions. So the mnemonic is Vindicate Me, which means vascular, infectious, neoplastic, degenerative, iatrogenic, congenital, autoimmune, traumatic, endocrine, metabolic. So these are all the etiologies that could give rise to dyspnea. Dyspnea is basically shortness of breath, if this is not clear to anyone. Right, so we go towards acute dyspnea now. So a general overview. First of all, what happens is that the patient comes to you with dyspnea, and then we have to look at the the presentation of the patient. Is if whether he has acute stridor or impending airway loss. If that is present, then we go towards a different management of the stridor. Then we obviously secure the airway, we intubate the patient, we calculate the GCIS score, and we have to stabilize the patient. If airway loss is imminent, then we have to secure the airway, intubate it, and then go forward. But if that is not present, then we have to look at the presence of hypotension or decreased breath sounds. So if hypotension and decreased breath sounds are present, then we go towards the pathway of going towards the bedside echo or doing the fast exam. If both of them are positive, which basically it is a part of imaging, both of them are types of imaging, and the fast exam basically shows us, it is basically an ultrasound of the complete body, and it shows us any fluid in any third space of any cavity or third space of the body. Whereas bedside echo is specifically the ultrasound of the heart, which if in turn, if any of these are positive, we go towards the trauma pathway. We have to stabilize the patient again. If fast or bedside echo are present, then the patient is likely unstable. Then we have to stabilize it, and the etiology would be cardiac tamponade. If the hypotension and bed sounds are not present, then we go towards the timeline, because then the patient is not really presenting with a dangerous condition. So we are now out of the part of managing the patient immediately. So now we look at the timeline so that we could understand if it is truly acute or if this is an exacerbation of an already present chronic condition. Right. So going back to the fast and bedside echo. So now you've done that and it is negative. So then you go towards the CT angiography of the chest. Now these two steps are not done immediately afterwards. There is a bit of an investigation in between, which I would discuss. But basically, why we're doing CT is to rule out pulmonary embolism. So if this is positive, then we go towards the pulmonary embolism pathway. We treat it through oxygen and anticoagulation and IVC filter and all that. But if once we've ruled out pulmonary embolism, then we go towards the EKG and troponins. Now, this is an amalgamation of both of these steps. So once we have found out that it is truly acute and we've ruled out the dangerous acute conditions, now we going towards an etiology relating to the cardiac subject. So then we look at the electrolytes and EKG, and if they're positive, obviously we go towards the uh, acute coronary syndrome and arrhythmia direction, and then we manage it accordingly. But if it is again negative, now we are um, strictly going to focus on the pulmonary aspect of the patient, We will carry out a pulmonary exam and we will check for hyperpnea, tachypnea, cough, or wheezing. So if it is wheezing, then we would concentrate on the COPD, asthma, and bronchitis pathway because it is mostly classically it is pathognomonic for asthma or COPD or bronchitis, the wheezing symptom. But hyperpnea and tachypnea would lead to us to checking the acid-base status of the patient, which would in turn lead us to check if it is acidosis. Then it would lead us to different differentials such as aspirin or sepsis. But if in the pulmonary exam there was one aspect of checking cough, so if you have looked for cough and it is present, then we would look for malaise and fever. Obviously, if fever is present, then we go for the respiratory infection pathway. If it is not, then we go for an intoxication or altered mental status. Or if the patient is elderly, we look for these signs. If these are present, then we would go for aspiration because in aspiration, the patient is either intoxicated, has either altered mental status, or is of an elderly population. Also, the patient would not have fever. He would, although, have cough and would have dyspnea, and pulmonary exam would also be abnormal. So this is how you go towards approach dyspneic patient. So if it is aspiration, then we give supportive care. There is no treatment for it. But if the patient does not improve on itself, then we go for the antibiotics. So this is a general overview, right? So this is basically the you can look for the short forms if you want to. So this is basically a general overview, right? And you can either remember this or you can either understand the rationale of each step, and by through that you can maybe memorize it a bit easier. It would be a bit easier for you to memorize it once you understand the reason why we do each step, which I'm going to explain now. So you can either memorize it like this as it is, or I could explain the rationale for doing the each step. So that would be a bit easier. Okay, so now we've looked at the flow chart. So step one would be to check for the immediate life threat. Is there acute stridor present? Which stridor basically points towards our impending airway loss. So basically, if this is your airway and there is any obstruction present, now the obstruction can be a foreign body, the obstruction could be any malignancy, the obstruction could be the closure of vocal cords, right? So you have vocal cords, so they could be closed, and that could also lead to a stridor. So any obstruction in the airway would compromise the airway, and that is dangerous. That is an emergency condition. So we need to stabilize the patient. We have to intubate the patient. So we intubate the patient, we safeguard the airway, and then we move forward. But if that is not present, then we go towards the main diagnostic pathway. So stridor is important. You have to remember the stridor is important. You need to secure the patient's airway if this is present. This points towards the loss of airway, right? Step two would be the rapid assessment for the big three critical conditions. Now, what are the big three critical conditions? The big three critical conditions are the conditions which are basically present in any emergency pulmonologic condition. You would have to remember the big three. Any case that is presented to you with an acute presentation or in an emergency setting, you would have to keep the big three in mind. What are the big three? So basically, going step by step, these are parallel checks for time sensitive life threatening causes. So you would check for them at the same time, not one after the other. This is just presented to you like this for understanding purposes, but all of these conditions are checked in a parallel manner, not one after another. First of all, you would check for pump problems, which is cardiac tamponade or tension pneumothorax. So this is like two of the big three conditions. What you would do is you would have to perform a bedside ultrasound, fast exam, or an echo. So you have to keep in mind the flow chart that we just saw. So you have to keep that in the back of your head and also listen to the explanation that I'm providing. So basically, two of the big three conditions is cardiac tamponade and renal tension pneumothorax. What you do is you perform a bedside ultrasound, fast exam, and an echo exam. So what it looks for is it looks for the cardiac tamponade, which is a fluid compressing the heart, or it looks for the pneumothorax, which is a collapsed lung. This can be diagnosed through X-ray also, but it is difficult. You can diagnose it through X-ray by looking at the diminished silhouette of a lung and um, also the change in the position of the trachea, shift in the position of the trachea or the shift in the mediastinum. You can also look at those signs, but those are non-specific. So you have to remember that you have to confirm pneumothorax by looking at the fast exam or the echo. Some high points. The next best step during this condition is the bedside ultrasound, which is the fastest and the most reliable bedside test. The test of choice and the test that confirms any of this condition for cardiac tamponade, it is an echocardiogram, or for tension pneumothorax, it is a clinical diagnosis. If once you do echo and you rule out cardiac tamponade, what happens is you're left with this condition, tension pneumothorax. So you go towards that. It presents with some classical symptoms such as hypotension, tracheal deviation, and absence of breath sounds. So you also keep in mind the case that we discussed in the beginning. And you have to remember that in step 2 CK, the question can present to you at any point in this flowchart or any step, right? It is not important that the question presents to you with starting as a patient coming to you with a complaint of dyspnea. It's not important that that is the starting point. The question can start from anywhere in the flowchart, and then they could ask you to now move forward from that point. So you need to understand each step clearly. How do we treat tension pneumothorax? We wait for a chest X-ray, and then we perform an immediate needle decompression. All right. Now we also check for pulmonary embolism. We also check pulmonary embolism, and we order a CT pulmonary angiograph to confirm. This is to confirm. Now, pulmonary embolism is a bit of a deep topic in which we have to look at the Wells score and then move forward with it. So it is not as simply we go for the CT pulmonary angiograph directly. That's not the case. We have to first look at the Wells score. But if the patient is unstable, then we first stabilize the patient. Obviously, that is a rule of thumb that you must understand. We first stabilize the patient with oxygen, then we stratify it according to the Wells score. If it is a high probability case, then we start anticoagulation while we also arrange for imaging. If it is a high probability case, then we do CT because it is an investigation of choice. If it is a high probability case, VQ scan is an alternative if the patient is pregnant or if the CT pulmonary angiography is contraindicated, such as in renal failure, because contrast can cause nephric toxicity. The treatment for this is therapeutic anticoagulation such as low molecular weight heparin or DOACs. And you can also place an IVC filter if it is contraindicated. If any anticoagulation is contraindicated, such as a patient which has gone recent surgery, so you can place an IVC filter in that patient. You also check for a heart attack, acute coronary syndrome, and you have to run tests like electrolytes, EKG, and troponins, so that you can look for a heart attack, arrhythmia, or an acute coronary syndrome presence. The best next step would be, in this case, to do the management of heart acute coronary syndrome, which is aspirin, oxygen, and also obtaining EKG. So you would learn that in the cardiac section. But this is a simplistic stabilization. The next best step would be aspirin, oxygen, and EKG. The test of choice to confirm an acute coronary syndrome would be serial troponins, and coronary angiography is the definitive diagnostic test. But it is very invasive, so what we do is first go towards the less invasive test, such as the serial troponins, and then we go towards the coronary angiography. If we have a high probability case, that is, then we go for coronary angiography. Do remember that CT pulmonary embolism case, all of this is not as simple as it is written here. The Wells score plays a big part in it. Then we evaluate, after doing all of these, we've checked for the big three, which was our second step. We've checked for them. But the third step is we evaluate the breathing pattern and symptoms. So if critical conditions are ruled out, you need to assess the patient's specific breathing pattern. The observation which we get from observing the patient is the patient is experiencing hyperapnea, tachypnea, or a cough. If yes to cough and wheezing, then it points towards mostly asthma, COPD, and bronchitis. And the high point is basically you stabilize the patient if it is an exacerbation of asthma or COPD. What we do is you have to first stabilize the patient. You have to give bronchodilators so that bronchospasm and wheezing is stopped. And the best test to diagnose this would be spirometry or pulmonary function test. But clinical assessment and response to treatment are key initially. So you would do spirometry once the patient is stable. But first of all, what you would do is you would use the bronchodilators to stabilize the patient. Right. So once we've checked for hyperpnea and tachypnea, we have to check for the acid-base balance, because obviously hyperpnea and tachypnea do change the acid-base balance of the body. So if the acidemia is present, now this is a case only highlighting acidemia. The reason is because acidemia is the most dangerous of them all. If the patient is having respiratory alkalosis or any kind of alkalosis, then that could be managed accordingly. But acidemia is quite dangerous. So we need to study about acidemia specifically. What we do is if we find acidemia, we investigate the causes of acidosis. And once we investigate the causes, the possible differentials would be aspirin overdose, sepsis, or decay. So all of these are emergency conditions. So you need to treat them as soon as possible. Right? You need to treat them as soon as possible to stabilize the patient. The next best step in this scenario would be to go for the full arterial blood gas composition, not just the respiratory exam, the full arterial blood gas of the body and the basic metabolic panel to confirm acidemia and determine the cause, if it is metabolic or respiratory. If we only go for what we were doing is first we were checking the respiratory alkalosis or acidosis if it is present. But now we go for the full arterial blood gas examination, which would tell us the exact cause. The investigation of choice would still be EBGs because it is crucial. And if we are suspecting salicylate poisoning, then we go for serum salicylate level. But we usually don't go towards this route. Salicylate poisoning questions usually present with the patient presenting, and we have to stabilize this patient, usually by giving sodium bicarbonate or any other antidote. So step 5 would be to consider infection. Now, all of these are, after ruling out all of these steps, we have to consider for infection in vulnerable patients, such as patients with altered mental status, or the elderly, or those who were intoxicated because they obviously cannot protect their own airway. And you also have to remember that dementia patients are also included in this demographic. Dementia patients, right? You have to remember. dementia patients. So if we find fever, we go towards the diagnosis of respiratory infection. But if the fever is not present, then we go towards diagnosis of aspiration. Because aspiration would not usually cause a fever. Aspiration can, however, lead to lung abscess formation, which can lead to fever, but that is a chronic, subacute kind of a presentation, which would present after 2 to 3 weeks of coughing and chest pain. The next best step would be to look at the chest X-ray to confirm for the infiltrates that would be present in infection and also in aspiration sometimes. The best test is chest X-ray. Initial test in sputum cultures, blood cultures are the confirmatory test if infection is present. But we usually don't do this for normal infections. We do this for as in sickle cell patient or as in a patient that is very toxic or looking like it's, it has the patient if it is looking like if the patient is in bad shape. So we go for these confirmatory tests or otherwise we treat the infections, normally community acquired infections, empirically. So treatment is supportive, oxygen, fluids, empiric antibiotics if pneumonia is suspected. As I said, we treat the community acquired infections empirically. If the patient is of a sickle cell condition or if the patient has any morphological defect such as COPD or any already present chronic condition, then we go for sputum cultures. Otherwise, we don't. Right? So that is basically, I think, the last step. And this is a summary of the high yield points. So if there is impending air loss, next best step is to secure the airway, intubation. This is a clinical assessment. Key treatment is standard protocol. If it is cardiac tamponade, then we go for the next best step, bedside echo. The best test would be echo. Again, pericardiocentesis is the treatment in emergency condition. If it is tension pneumothorax, we go for immediate needle decompression. There's a clinical diagnosis. Chest tube is a treatment. First, we do needle decompression and then we go for chest tube. If it is a pulmonary embolism case, we do the therapeutic anticoagulation. Best test is CT, anticoagulation, IVC filter if contraindicated. Acute coronary syndrome, heart attack, we would do aspirin, EKG. Serial troponins coronary angiography is the best test. Revascularization is the treatment. Asthma, COPD exacerbation, inhaled bronchodilators is the key next best step. Spirometry is the best test, and steroids and oxygen can be used to stabilize the patient if it is an acute exacerbation. Acidemia, aspirin, overdose, check for arterial blood gas, and the best test would be ABGs. Again, give bicarbonate or do dialysis. In case of pneumonia, aspiration, you would go for chest X-ray, and best test would still be chest X-ray, and you would give empiric antibiotics. So the answer to our question in the first slide, the answer to this question, you can pause it and read it again if you want. So the answer to this question would be emergent pericardiocentesis because it is a pump problem. It has typical Beck triad present in the stem, such as hypotension, decreased heart sounds, and is also represents obstructive shock, which is represented by the patient's hypotension. So this is the most immediate life threat. So we would do emergent pericardiocentesis. Right. Also, this is an explanation for other options as well. The question forces you to prioritize the pump problem branch of the algorithm over the clot problem, even if the patient is strong PE risk factor. So, what PE risk factors that the patient has is such as he was diagnosed with DVT, right? And he's also old, He has diabetes and coronary artery disease. So all of these, he also has hypertension. So all of these do push you towards pulmonary embolism kind of a presentation, but you have to be careful. Okay, so you can read the explanation in this slide. Moving on, this is just a mention of the Weld score, so that you don't you don't think of you don't forget about this, because this is very high yield. This is high yield, right? This is the Wells criteria. Clinical signs of DVT 3 points. Pulmonary embolism is the number one diagnosis 3 points. Heart rate greater than 100 1.5. Immobilization or surgery 1.5. Previous DVT is 1.5 points. Hemoptysis at 1 point. Malignancy is 1 point. So if you can remember this, this is important. This comes in your paper. But if you cannot, we can discuss it in other lectures on how I remembered this for my time. Interpretation is score greater than 4 would get you to the high probability, which is 50% chance of PE. Empiric anticoagulation should be started. Score from 2 to 4 is moderate probability, and score less than 2 is low. So you first stabilize the patient, and then you do CT if it is high probability. I have explained it here. So if it is high Wells score, you directly go to anticoagulation and then CT. If it is a high score and the patient is unstable, so you directly go towards the anticoagulation. If it is a low score or moderate Wells score, you go towards the D dimer test, and then you go towards the CT pulmonary angiography if the D dimer is positive. So you have to remember this. All of this is important. This would be further discussed in the pulmonary embolism subject, but this is quite important. So remember this. This is a CT of the pulmonary embolism. You can see this arrow pointing towards that. You can see this arrow pointing towards this. This is the pulmonary embolism. Take a second and look at this CT. Memorize it. And this is a cardiac tamponade ultrasound. You can see there is a pericardial effusion outside of the right ventricle. So also memorize this image. Images are very important for step 2 CK. So that's probably it. Um, as I've said, you could have 1,000 questions right now of why we don't do this step, why we're going towards that step, why this, why not that, why specifically going towards this examination. But all of these questions, you can put them in the comments and I can answer them. The basic overview of approaching acute dyspnea is the one that I have given you in this lecture. If you remember that, you would be set to approach acute dyspnea patients or acute dyspnea questions or acute dyspnea cases if you're going towards step 3. It is understandable to question every step, and you should, but this is a basic overview of what you should remember these steps for acute dyspnea approach. So this is a slight overview. It has UWorld and NBME points incorporated in it, and I've also incorporated some emboss points in it as well. So that's it.